stuff to cover. We have a lot of stuff to cover, and I'm gonna go pretty quickly. So anyway, welcome to Echo. Next slide. These are just our usual introductory slides. A nod to all of our supporters. Next slide. And a reminder that we have to keep everything HIPAA compliant. This is a safe learning environment. We strive to encourage one another. Next slide. And we're going to cover 4 different areas. We're going to just talk about wellness, talk about age-friendly health system strategies, in particular today about advanced care planning, a little bit about QI, and then also updates on COVID regulatory guidance. Next slide. And a reminder that if you want CME credits, you need to complete an evaluation. The link will be put into the chat box towards the end of this session. So thank you. Okay, and also I just want to mention that, as you know, we have been teaching a lot about age-friendly health systems, and IHI is now putting together an opportunity to get age-friendly health system recognition. And so there's a bunch of things to, fill out, some check boxes and stuff like that. But this is stuff you're already doing. And so if you would like to get age-friendly health systems recognition for the excellent work you're doing, we can help facilitate that for you. And we'll talk more about that later, but I just wanted to give you a heads up about that. In particular, folks who are already doing initiatives on quality improvement. Okay, next slide. Okay, this is part of the 4-part series of What Matters, and we are now on April. Next slide. And just an introduction to our team here. I'm the course director, and Hope Young is here, and she's from Kakuamau, and she's going to be our guest speaker and talk about advanced care planning. We have Gail here from Oahu Care Facility, and Dana Mitchell from Mountain Pacific, and Lori Henning from HAH. Thank you guys for joining. Okay, all right, so Gail, go ahead. You can talk about wellness for us.
Yeah, so, in the last couple of years, we've all been kind of super stressed out. So we're working on our wellness now, trying to get some rest. And what are we doing for rest? Because a lot of us don't realize that sometimes rest could be just stop what you're thinking, get some quiet time, decrease the noise. And that could be rest. In addition to now looking at how do we restore ourselves. So you want to make sure that maybe your part of restoring would be writing it out, removing distractions, and just doing something you like to do. And that's where we come with creating. So how do you create something? Because it could be where you're just using your senses, like maybe baking a cake or drawing. So think of things you can create, because everybody creates differently. And sometimes when we're creating things, we feel good about ourselves, and that helps us with our well-being. And then we also have where we're connecting. And I think this is what we're trying to do now, because we've been so closed up. And so now we're reaching out with our friends and, trying to make arrangements for, maybe going out to lunch and trying some different things that we haven't been doing in the last 2.5 years, which can help with our well-being and making us feel a whole lot better. So, what are some of you doing? And you can throw that in the chat box if you feel up to sharing, because it's probably not, you want to get into rhythm with your well-being. And so some of us look at rest as like getting a 8-hour sleep, but it could be, just 10 minutes. And so I'd like to hear if you'd like to throw something in the chat box. We can say what you're thinking. And anyway, it's kind of important that we put everything back into our life, and we want to start doing it this week. So I want to see what you have to say in the chat. And if there's nothing, that's fine too. Maybe later on in the program, you can mention something that you've been doing that sounds kind of awesome that we can share. And I think we could move on to our updates for COVID from Laurie Henning. Is that correct? Yes.
Yes, thank you, Gail.
You're
Okay, I'm gonna
welcome.
John, can you pull up? Yeah.
there we go. I'm going to share my screen. So I have a couple of updates to go through for you today. So with regards to guidance, so on April 5th, CMS released revised interpretive guidance to clarify expectations for assessing compliance with the COVID-19 vaccine mandate interim final rule. So included in the revision were updates to the FTAG F888.
Oh, sorry.
Verifying-
Are you trying to, did you share your screen yet? We
Yeah, can you see it?
No, no.
Oh, let me do that again.
Okay,
Can
got
you
it.
see it now? Great. Okay. So, so with regard to FTAG 888, they clarified what surveyors are using to get their sampling of staff for review, noting that it will include contracted staff. And it also states that surveyors can modify the review if the facility was found to be in compliance with the rule within the last 6 weeks, if they were in the facility setting and already did that. It also says that a review is not necessary if a surveyor is there for the life safety code complaint or a follow-up survey for life safety. So also to note that they clearly state that a failure to provide evidence of vaccination status for contracted staff demonstrates non-compliance, and it should be cited at F888. And then they expanded upon options to lower the scope and severity of tags to recognize good faith efforts. So if a facility has limited or no access to the vaccine and they've documented attempts to gain access, that's a situation where they would still be cited, but surveyors can lower the scope and severity of the tag. Or they listed another scenario. If the facility shows evidence that they've taken active steps to get all their staff vaccinated and they have policies and procedures in place, then again, surveyors are still going to issue that citation, but they can lower the scope and severity of it. So I've included a link to the long-term care and skilled nursing facility attachment A for you here, and more detail can be found there about that. And then each month I've been showing you the community transmission data that nursing facilities use to determine the frequency of testing for staff who are not up to date with their vaccinations. And so you may recall that the CDC made some changes to their website and they have some data available for public use. And I wanted to take a quick look at the website to show you how to get the information that nursing facilities need, because we have had questions on that. Folks have gotten a little bit confused on where to go. So if you go to the website, you're at the COVID data tracker, and if you scroll down, you're going to see this nice map that's all green. And so that is for the public use. There's only 3 colors listed here for high, medium, and low levels. And so again, this is for somebody, general public use. So for example, if an immunocompromised person wanted to evaluate whether they should take precautions in a certain region by wearing a mask, they could visit this website and make a decision as to what they feel is best for them. So, so here, once you get to this slide, you're going to go to data type for the nursing facilities. This is where you find your data. You're going to go down, scroll down to community transmission. See if I can get it to go. There we go. And now you see our nice little map here with all the colors. And this indicates, what we are supposed to be following based on QSO memos of the high, substantial, moderate, and low category levels. And so now from this point, you can see, you go up here and you can select our state to dive down into it and see specifically the data related to Hawaii. So again, you're going to see the color coding here. We can go down and see where we've got as far as high, and the rest of our state is in a substantial level. So that's where you go to. And if you scroll down this, you're going to find lots of data points that you can pull from with what's going on. So I just wanted to show that there for you. I'm going to go back to my slides. Okay, so here we can see this is related to determining community transmission. So folks are asking, how is the CDC determining the level of transmission within the counties? So currently they're looking at two metrics. They look at new cases per 100,000 over the last 7 days, and also the percent of positive tests over the last 7 days. So based on that, the counties are placed in one of these categories below, between low and high. And as a note, if a county falls into two different categories using those measures, then you use the higher of the two. So for example, this is Hawaii's data for last week, dated Sunday, April 3rd through Saturday, April 9th. And you can see that here, if we take the new cases just in Honolulu County at 90.6, go up and find it for new cases over here, you're going to see that ranges under substantial. Then for percent positive tests, we've got 6.21%. Again, we're going up here, percent of positive tests. 6 falls under the moderate category. So between the two, you would take the higher of the two. So our level of COVID-19 community transmission is going to be at the substantial level. So there's a link here for more information about the testing requirements for nursing facilities. It was last updated on March 10th. So, and just as a reminder that at this time, the CDC continues to recommend that healthcare settings follow infection prevention and control practices to reduce the risk of transmission of COVID-19. And then if we take a look at the Department of Health dashboard, statewide, we have ticked up a bit in the number of positive tests. So basically all counties have seen an increase at some point over the last 7 days, with the exception of Kauai. You can see here, and then also Maui County ticked up, but we can see that they are on the decline there. So taking a look at our data, we added some markers at random numbers just to kind of show for scale. So our total confirmed COVID-19 patients in hospital beds in our state remains at a lower rate. And so, you know, again, these numbers down here, they went up a little bit, but we're headed back down again. And then as you can see here, our ICU bed usage in the state is looking the best it ever has been since the beginning of the pandemic. We're down here, this number says 3 back here a few days ago, and that's just lower than we've seen, you know, throughout the entire duration. And then the total new COVID-19 hospital admissions continues to be low. So again, great news on that front. And then this data is from March 31st to April 6th, 2022. And it shows that Hawaii has the 15th highest infection rate in the nation. However, for the entire duration of the pandemic, which they define as March 7th, 2020, through right now, this data runs through April 6th, 2022. Hawaii continues to have had the lowest infection rate in the nation overall. For the week of March 31st through April 6th, Hawaii had the 11th lowest death rate in the nation, and that is up from being 5th lowest in the previous week. And then as we look at our ranking for the entire duration of the pandemic, Hawaii continues to have had the 2nd lowest death rate in the nation, second only to Vermont. And then as you can see here, an overall look at the pandemic, this is Hawaii's infection rate. It's declined significantly from our last surge. So the print on this is pretty small, but you can see that by the time we got to the end of February, we were at 76 per 100,000. Then we went down to 48. And the latest data puts us at 65 per 100,000. So thank you to everyone for all that you're doing and that you continue to do to keep your residents safe and take care of the necessary precautions to manage COVID-19 and hopefully keep it out of your facility. Dr. Nguyen, I'll turn it back over to you.
Okay, thank you. Actually, so John, if we could put up the slides again, we're going to move on to have Hope share with us what matters series and talking about next slide. Let's talk story. Go for it, Hope. Thank you. You're muted.
There we go. Thank you, Dr. Nguyen. Hi, I'm Hope Young. I'm from Kokuamau. We are a community benefit organization with our goal as improving care. So how do we do that? One of the ways that we do that is through advanced care planning. And today's discussion will be on the documents that can support your advanced care planning wishes. So why is advanced care planning important? Well, obviously, because no one knows when they're going to become very ill. And now that I have your attention, I'd like to ask you folks, how many of you actually have your advance directive? So we're going to be talking about advanced directives and PULSE today, but I'd like to see if folks out there, if you could drop it in the chat, let me know if you have done your own advanced directive. It'll be an interesting thing to look at afterwards. So again, advanced care planning, no one really prepares to become very ill. And what this really does is it eases the burden for your loved ones, and for you folks as care home operators as well. So Woody Allen has a great quote. I'm not afraid of death. I just don't want to be there when it happens. And I could completely agree with you there, Woody. So why do we do advanced care planning? It's really a bunch of different reasons, but first and foremost, who would speak for you? What if something were to happen to you and the unexpected happened? Who would be your advocate? Who would be your champion? Who would be the person that you trust to speak for you? And would they know what you want or possibly what you don't want? This is really important. How do we advocate for someone if we don't know what their wishes are? Which is why advanced care planning is really important. Especially you folks out there probably know this. I'm preaching to the choir when it comes to advanced care planning and why it's so important. So did you know that everyone over the age of 18 should actually have an advanced directive that names the person that they trust to make decisions on their behalf? It also gives them directions for what they can do to support you in case of a serious illness. Without an advanced directive, and some of you may be familiar with what happens without one, but there is no next of kin rule. Here in Hawaii, it's not the next of kin that takes over the healthcare decision-making. We actually have to have a hui approach, and they will call people in who want to be involved with the care for the individual. And those people, those loved ones, have to come to an agreement with who's in charge. Now, I don't know about your family, but when it comes to my family, that can be a challenge because every member has their own opinions. So I would much rather name who I'd like to be in charge versus leaving it up to chance. But without an advance directive, precious time could be wasted trying to get to that point by having to go through the courts. Rather than wasting time, let's have these documents completed so that you don't have to go to courts to get guardianship. Because prior to the pandemic, it could take 6 months to resolve. My understanding is now that it's taking quite much longer for guardianship cases. So we want to encourage folks to cover all their bases because there are different types of planning, and advanced care planning, it covers a bunch of different things, but we want to make sure that folks have this, have their wishes known as well as documented. Our advanced directive, which you can find on our website, it is free to download, kokuamau.org. It's a legal document. So advanced directive legal document only can be completed when people are of sound mind. It does appoint your healthcare power of attorney. I also call that person your healthcare agent. Also use the word champion or advocate. This is the person that you determine you trust to speak on your behalf when you're unable to. And then it has a living will section of it where it gives instructions for future choices on end-of-life decisions. So how do we go about this form? Well, the first section is really determining who your agent is, who your healthcare power of attorney is, who that person is that you trust to make decisions when you're unable to speak for yourself. And keep in mind, it doesn't need to be a family member. It can also, and you would also want to select an alternate so that you have a backup just in case something should happen to you and your number one decision maker. The end of life decisions, this document really has to have certain circumstances in order for it to become effective. And I'm not going to read this to you, but one that's most highly used is when you're unable to speak for yourself. Who is going to speak for you, right? First choice on this document is asking whether you want to prolong or not prolong life. Well, the choices that they have there is I want to stop or hold medical treatment that would prolong my life, or I want medical treatment that would prolong my life as long as possible within the limits of generally accepted healthcare standards. That's a mouthful. So how do we put this in layman's term? Well, if you've ever been to the hospital and visited somebody in the ICU, that is generally accepted healthcare standards. There are medical interventions that are helping to keep a person alive. And that is what that could look like. Versus the first statement, I want to stop or hold medical treatment that would prolong my life. This is really choosing to not have all that medical intervention and allowing nature to take its course in whatever setting the person would like to be in. Second part of this is on artificial nutrition and hydration. And it's really important to discuss this because here in Hawaii, we all know food is part of our culture. Food is a way of showing aloha with each other. We share food with people, and likewise with artificial nutrition and hydration, there should be a conversation about what this means to the individual. So quick story, my mom, when she was in the ICU, she had Parkinson's and she also had congestive heart failure. She had a few things going on with her, but in her documents on both her advance directive and her post, she said that she would try artificial nutrition and hydration. So when we found ourselves at the ICU bedside with mom, they attempted to do a nasogastro tube, which goes up the nose, down the throat, and into the belly for feeding the nutrition. The first time the nurse came in and put the tube in, she immediately said, "Get it out, it hurts." The second time, a couple of hours later, got it in, she immediately said, "Get it out, it hurts." So when they tried one more time, she basically told them to get out of the room and stop trying to feed her that way. It's important to note that although her documents said that she would try it, she still was able to direct her care verbally and tell us what she wanted. So the documents are not set in stone. As long as the individual is able to express their wishes, they can continue to do so. With artificial nutrition and hydration, it is an individual decision. It's a very personal decision. And in some cases, it can prolong life. People have lived for years with a feeding tube. In other cases, especially those at the end of life, it may not prolong life. And in fact, it could actually prolong the dying process. So it's important to think these things through when creating the documents. What would you want? What would you not want? And if you decide that you would want a trial period, or if the individual would like to try the feeding tube, then it's also important to recognize that at the end of that trial period, there is removing of that tube if it's not helping. And that can be kind of devastating for some folks. So make sure if you're completing your own advance directive that you're taking these things into consideration. If you're helping someone else to do this for a patient or a loved one, keep that in mind as well, that this is a decision that they should really take into consideration. The next sections are on relief from pain and other important considerations. Pain medications, it is a personal one. You can choose whether you'd like to have the option of having pain relief, or you can express why you wouldn't want it in the next section. Again, these are personal decisions that folks should make for themselves. In section 2, in part 2, section E, what's important to me, this is when you can actually write down what really matters. So this is where you could say, hey, you know what, as long as I can eat my steak and watch my Korean soaps, we're good to go. Or you could put something in there like, hey, if I get dementia, don't chase me around trying to give me cholesterol medications. feed me the ice cream and let me be happy. This is where you put it all in your own words. And really, this is where you get to give your directions to your agent. In order for this document to be legal, it needs to be notarized or signed by 2 witnesses. Now, the tricky part with the witnesses is that it cannot be someone who is providing care or is an employee of the healthcare facility. So you folks would not be able to sign as a witness for someone who is in your homes. The witness also must be over the age of 18, and 1 witness cannot have inheritance rights. So some people prefer the notary, but either way, they're both acceptable means of making this document legal. Once you have the document completed, you want to make copies of it and have copies sent to the primary care physician. If they're members of a health system, it would be helpful so that it's in their EMRs. The person who has agreed to be the agents should get a copy of this. And you can keep in mind that this can be digital copies. They don't necessarily need to be paper copies in order for you to show that you have a copy of it. The next section is on POLST. So what exactly is POLST? Well, providers' orders for life-sustaining treatment. This is a standing medical order, which must be completed by a provider, either an APRN or a doctor. They must sign off on this. And that's because their license is on the line when they're creating this POLST. So there should be some conversations regarding the decisions made on a POLST form. Who would benefit from having a POLST form? Now, oftentimes we hear folks say, oh, everybody in a nursing home should have a form. Well, they may be eligible, they may be close to needing one, but they're not necessarily required to have one. The demographics for these people, they would have chronic or progressive illnesses, serious health conditions, maybe they're medically frail. It's for someone who you would issue an inpatient DNR order. Or the easiest way to navigate this question is, would you be surprised if this patient were to die within the next year? If this resident, if you're thinking about who might need one, and your answer is no, I wouldn't be too surprised, then they would be a good candidate for a POLST. So POLST in Hawaii, again, it is not mandated, but honoring it is. And the POLST itself provides immunity from civil or criminal liability. By honoring the POLST, you are honoring the resident and the resident's wishes. Hopefully that was discussed with their physician, sorry. POLST in Hawaii, it was started in 2009, updated in 2014 to add the APRNs to be able to sign off on a POLST. The first section of it, it's who the POLST is for, their patient demographics and the date of birth and the date the form was prepared. On the back of it, there's a part of it that says patient's preferred emergency contact or legally authorized representative. Keep in mind, ideally, it should be whomever was named as the agent in the advance directive. So the person who's being the healthcare power of attorney, that would ideally be your legally authorized representative. However, if the individual does have capacity, they are able to sign for themselves, and this would just be for emergency contacts. Now, the first section on this, CPR, the person has no pulse and is not breathing. Pop quiz, drop it in the chat. What are they? If they have no pulse and they are not breathing, I will give you 5 seconds to see if anybody's got fast typing fingers in there. If they have no pulse and they are not breathing, yes, absolutely, they have died. They are dead. So the first section of this document is asking, if we were to find an individual who has no pulse and is not breathing, AKA dead, would you like us to attempt resuscitation? Or would you like us to allow for a natural death? Now, I'll invite you all to take your thumb and your first finger and guesstimate 3 inches. This is the amount of space you have to push into a chest in order to be effective. You have to actually, when you're doing CPR, you're pushing into the chest to get the heart beating. You have to push this far into the chest in order for that to be even slightly effective. And so it is something that take some effort. If you've ever seen it done in person, it can be rather violent. If people are using their awareness for what they've seen on TV, people get CPR all the time and they go golfing the next day. That is not quite accurate. As we know, CPR is a little bit more, as we get older, CPR gets less and less effective. So something to keep in mind when you're talking to residents about their wishes for CPR, and ensuring that they understand what's involved. Because oftentimes you will hear people say, of course I want to try, I want CPR, not knowing what it actually involves. You can also use the terminology allow natural death. Oftentimes when people hear do not attempt resuscitation, they think that you're withholding care, and that is not what we're doing, right? So sometimes terminology makes a difference with how the information is received. So the next section, the person has a pulse and they are breathing. What level of intervention would you want? So you have comfort measures, limited additional intervention, and full treatment. Now, what do each of those look like? Well, comfort measures, it's often folks who don't want to be in a facility. They don't want to go to the hospital. This could also be folks who are on hospice. Maybe they're comfortable in whatever location they are. When you're looking at limited additional interventions, this is kind of where you get to choose what you would want to try, what you don't want to try, but you're trying to stay out of intensive care. So you're trying to avoid the ICU. And then, of course, full treatment is where you get all the medical interventions that's available that could help. And so how do we know what happens if the individual chooses to get CPR? They have no choice, but they're going to full treatment. If you are able to revive them, they will have all the medical intervention and support that they need to recover from the CPR. If, however, they choose to allow for a natural death, they get to choose what level of care they would want. They can choose comfort measures, limited intervention, or even full treatment. This is another discussion to have with the physician or the APRN who's actually filling out the forms, so that there's an understanding of what these different levels could look like for that person. Section C, again, we're back with food. Food is love. This is an opportunity to show what would you like as far as artificially administered nutrition. And it's always important to remind that food is always going to be attempted to feed by mouth. But this is in addition to those directions. So would you want artificial long-term feeding? Would you want no artificial feeding? Would you want to try it out and see if it helps? This is section C. Section D, these are the signatures for the people who are signing on the document. So we will have the physician or the APRN, their signature goes at the bottom. Then you want to, if the resident is of capacity, they have capacity, have them sign on their own. They should be signing for themselves for as long as possible. If they're unable to sign for themselves, then we're looking for the legally authorized representative. How do we determine who that person is? Well, again, if they are named on the advance directive, they are their healthcare power of attorney and they are legally authorized to sign on this. If there's a minor, it could be the parent of the minor. If it's a patient designated surrogate, this is where patient has said in front of medical staff, I would like my daughter to be in charge. This is a patient designated surrogate. The surrogate selected by consensus of interested persons, this is that HUI approach where they bring all the loved ones together and they ask all the loved ones to determine who's in charge. This can be a challenge if you have a big family, if you have lots of people who want to be involved, but naming that person as the surrogate can be done at the bottom of this form, or a guardian. Now, for this surrogate, only needs to be completed if the patient lacks capacity and is not designated a healthcare power of attorney. So this is section E on the back of the form. This is where you can enter the non-designated surrogate and that person who is responsible for the decision-making. Some practical considerations with regards to the pulse is it should be someplace where it can be seen. where it can be readily seen, whether that's bedside, by the patient, on the wall, near a bathroom, someplace easily visible, so that when first responders come to the home, they're able to scan the area and quickly find that form. So make sure it's someplace that they can find it. The pulse travels with the person. So if there is an emergency and they are taken to a hospital or the ER, have them take their forms with them. It should travel with them. So if you are still not sure about the difference between the advance directive and the pulse, I invite you to take a picture of this. This can help with recognizing which document is for what. For advance directives, we're encouraging everyone over the age of 18 to complete theirs. So again, if you haven't already put it in the chat, let me know if you have your advance directive. If you don't, that's fine. This is going to be motivation for you to go and do your own. With the advance directive, it appoints your healthcare representative. It appoints that person that you trust to speak on your behalf. This is a legal document. Now the pulse is, it's talking about right here, right now, what are the medical decisions that we would be looking at? These are actionable orders by first responders, and it does address CPR and do not resuscitate orders on the pulse. So difference between the advance directives and the pulse, we do suggest that the person, if they have a pulse but no advance directive, we would encourage them to complete the advance directive so that we can have that healthcare power of attorney named in a document. Now, we'll get back to the fun of pulse. Sorry, I'm trying to forward the slides. Okay, so when does pulse fit in? The pulse should be, so we're starting with advanced directives at age 18. And as we go through life, we're reviewing, changing, updating. And then when there's a diagnosis of a serious or chronic illness, that's when we're looking at completing the pulse form. And these two documents are working together to ensure that wishes are honored and known. So can the pulse be changed? Absolutely. A person can change their pulse at any time. People with capacity can change, revoke, or update their pulse at any time. When you have a pulse and it's a new pulse, this is an opportunity to build awareness and understanding of healthcare decision-making that may happen in the future. This is also an opportunity to introduce the concept of palliative care, as well as the concept of hospice and what the two are and how they can help an individual who's facing serious illness. This is also an opportunity to change the question of what's the matter with me to what matters to me. And hopefully you can take this as an opportunity to have a conversation so that you can support the individual with their wishes being known. Our resources have been translated into 10 different languages. If you need something that's in a different language, take a look at our website. You may find the language that you're needing. If you do use the translations to complete the documents, we do encourage you to do this on an English document. So use the translations as a tool, as a resource, and then complete it on an actual English version. Now, here is my contact information. I invite you to go ahead and write it down if you have questions on the documents. I'm happy to field those for you. We also do training. I realize this has been a 4-part webinar. But if you would like more information or you would like more tools in order to complete advanced directives with your patients, with your residents, or even for yourselves, you can reach out to us and we can help you with doing that with either additional training or the resources that we have online. The Conversation Project is one of those things that we use dearly. So if you'd like more assistance with using their tools and resources, we're happy to help you with that as well. Thanks, Michaela. I'm giving you back a little bit of time. But if you have questions, feel free to go ahead and put them in the chat. I'm going to give up remote control. John, you can take it back.
Okay. All right. Thanks. Wow, Hope, that was really good. Very informative. So I'm going to just talk a little bit about QI strategies and sort of how they relate to our regs in long-term care. Go ahead, next slide. So I think we pretty much covered this. This is just kind of a definition from Dying in America, which was a report that came from the National Academy of Sciences in 2014. And the thing that I think is most important related to quality is that where it says the process can start at any time and be revisited periodically, but it becomes more focused as health status changes. So it's a living process, just like your quality processes. Next slide. So then in the regs in the state operations manual, there's a lot in here too. But what I wanted to point out is that down there, sort of in the bottom half, that it says, although a facility's care must reflect a resident's wishes as expressed in their directives and in accordance with law, the presence of a directive does not, where did I lost my place, does not absolve you from giving supportive and other pertinent care that is not prohibited by the advanced directive. So they're not giving up everything, just like, you know, Hope described the various levels of care that somebody might wish to receive at the end of life. It also says in the regs that you are also not required to implement one if, as a matter of conscience, this was something that was kind of new to me, if as a matter of conscience, the provider cannot implement it and the state law allows for conscientious objection. Now, I don't know, Dr. Wen, if you know what Hawaii says about that. I don't have any idea what Alaska or Hawaii does. And I'd never heard of an instance where this has occurred, but it does say that in the state operations manual. Next slide. So here's our requirements. 10,000 foot view. Obviously, you have to provide your written information about the right to formulate a directive. You're providing that to the resident and the family. You have to document in the record. You cannot provision care or discriminate against a resident due to the presence or absence of an advanced directive. And, you know, we always have to educate staff on policies and procedures. Next slide. So again, just reiterating, the presence of a DNR, again, is not sufficient to indicate that they're declining other services. And so we covered that a little bit ago. So same with the advanced care plan as well as, or the advanced directive plus the DNR, doesn't mean they're declining other things. So you've got to tease all that out. Next slide. So in order to kind of avoid some citations related to your advanced care planning, you've got to ensure the surveyors are going to come make sure that your care plan's resident-centered, individualized, and consistent with their wishes as they are, you know, at the time that the surveyor is in the building. That you implement all the appropriate interventions, or if there's some reason why you can't or shouldn't, you have to make sure you have that all thoroughly documented. And you still are providing care based on the resident's needs. Now, where they mention specific instances in the state operations manual are in relation to, for example, the development or prevention of pressure ulcers or catheters. There may be interventions that you cannot do that would address those conditions. And as long as you've got it documented, the full extent of the care and why you can't do interventions that might not be exclusively prohibited by the advanced directives or included in the advanced directives, you can avoid citations or getting dinged on those in your QMs. Same with ordering and withholding of certain medications. Okay, so here in the QI portion, so for your quality improvement process around advanced directives, and I know where I was working on, where I was working previously, we had a really hard time getting our arms around the whole advanced directive process. So tips for how to make sure that you can get yours around are periodically assess how many residents you have in your care who do have advanced directives in place. Assess it periodically. So determine, you know, whether you're going to do it annually, quarterly at their care conference, or at any change of condition. Document that in your policies and procedures and ensure that you're following through on those so that you can constantly keep on top of those who do or do not have advanced directives, and either get them in place or update them in case their wishes change. Educate on strategies for having compassionate end-of-life conversations. Consider adjusting your efforts to boost completion. I ran across an article that this was a hospital-based scenario, but I thought it was really interesting where they hosted, it wasn't an event, it was like every, first Thursday of the month or something like that. They set up tables within the medical center and were there to help people develop or learn about advanced directives. And I think that a strategy like that could be adapted to a SNF. Developing awareness or education campaigns for your residents and families, and always ensure you've got your appropriate staff members on your palliative team. So, and then here's a list of some of the resources. Again, the conversation project is in there, so that's been listed twice. So obviously that's a good place to go. So we were curious if folks, do you all, I guess a yes or a no, or if you wanted to speak up and speak to how you ensure you've got advanced directives covered in your facility. What strategies have you used? Do you know how many people do or don't have them? Let's open it up for conversation.
Yeah, I thought it was really important for you to mention that, DNR doesn't mean do not treat. There's so many people who believe that. I think it's just really important to don't make assumptions and to just, talk about that as well, because people have had bad experiences before. And I think that's a really important thing to bring up. So thank you very much for bringing that one up.
And I noticed the audience, I asked if folks have their own advanced directives, and I don't see anyone who has one. So your challenge, folks, is to do your own, please. It's really hard to lead these conversations if you have not tried to do it for yourself. So I encourage you all, you have been challenged by Hope at Kokoamau to do your own advanced directive.
Yeah, I know I don't have one. And that's been one of those things that, my husband and I are like, we've got to sit down and do this. Thankfully, I know my parents do, but I don't know what it says. So that's another step forward. I have to, I know I have to make decisions, but I don't know what kind of decisions I'm supposed to make. So yeah, the homework expands.
Yeah,
It's
conversation.
Yeah.
Yes, it's a real challenge for folks to sometimes have these conversations, but almost all of the people who we've challenged to do this, they have all said they felt a sense of relief, a sense that I knew I had to do it and I finally got that checked off. So you have been challenged.
Great. I don't know, Gail, if you're on, if you want to share how your facility does this, or, do you guys have a regular way of checking when and if people have advanced directives? I hope she's still there. Anybody else want to share if they have a strategy of checking?
I was on another call with a care home provider, and they have they have 2 dates on their calendars. That's the 2 dates that they updated. So one is on National Healthcare Decisions Day, which is the day after taxes. So that's their first day that they're checking everybody's. And then the second one is in Thanksgiving, around Thanksgiving, before Thanksgiving. But they just set a date on the calendar, and those are the 2 dates that they go through everyone's who's in the home.
That's smart, because then, I fear that if you're only doing it annually and somebody has a change in status, change in condition a month or 2 after you just reviewed it, and you don't go back, you'll catch it at that 6-month marker that, 3 or 4 months after, as opposed to waiting another whole year. And then who knows if you've done damage in the meantime.
Right.
And that pre-holiday season is perfect.
Yeah.
'cause,
Yeah.
you know, that's when a whole ton of people start visiting, right? And so it's a good chance just to catch people and talk about it when things aren't desperate, but when things are, you know, relatively happy.
Right.
So I think that's a great strategy. Anybody else have other strategies they want to share? Any other suggestions? You know, I was just a little bit different. Dana, it was very intriguing when you mentioned about if people have advanced directives that you don't agree with as a provider, and you know, what do you do with that? And you know, the thought I had, and I was thinking, yeah, actually, that does come up, and yeah, it can lead to some pretty ethical. You feel, you know, you don't want to
Yeah.
do unethical things, right? And you don't want to disregard them, but on the other hand, you don't think they're making the right decision, you know, and then you're fighting with the family over because half the family wants this and half the family wants that. And I would suggest that maybe take it up with an ethics team or committee or something like that. Facility may or may not have one, but the hospital usually does. And so, you know, I don't think it hurts to ask the hospital if they could, if you could bring it up at their ethics committee and then have a discussion, just document that in the chart. And so whatever decision you do make, it's backed up by the ethics committee comments. At
Yeah,
least,
and I would be interested now, you know, like I say, I hadn't run across that before as an issue or even knew that that was in the regs. I'd be curious, since it says it's also dependent upon state law, what the state statutes say, how that's worded. What's Maggie?
great. Yeah, any other, oh, okay, here, Maggie says, on a transfer from the hospital required to have the document, if the facility doesn't receive, then the hospital team requests they call to get it. Yeah, well, Maggie, you wanna elaborate on that?
Just in one of our community coalition groups, it's been a big request at the hospital setting that if the skilled facility does not get the required advanced healthcare planning documents or the post, that the facility call them right away so that they can get it. So that's one thing that particular group has been actively working on for consistency and just making sure that everyone gets the information they need on a discharge transfer, going and coming back.
They may have it, they just a little bit overlooked, right?
Right,
So
right.
Don't want to forget it, but if you get nagged enough times, I guess you always remember that, oh yeah, that place always wants it.
Yeah.
Mhm.
Thank you for
Yeah,
that. That's a good
And the
strategy.
facilities that I've been in, our admissions coordinators would check that paperwork, right? And then exactly as Maggie said, they'd follow up with the hospital to see if it was on file and if we could get it. And if not, then the social workers were sent in with the advanced care planning document as a resource to the resident and the families to walk them through, and also with the post. And they would have that discussion with them as part of their initial assessment. And then, you know, welcome that when the physician came and did their rounds, that they could also speak to the physician and have any questions answered. And then it would get addressed and updated as needed throughout the quarterly care plans thereafter.
Do facilities address it at their quarterly care plans? Any other strategies folks use? Well, I'm gonna, yeah, so as Hope was saying, this is a challenge to everybody to, let's think about maybe a facility-wide strategy for opening up these discussions. Maybe have a little, you know, talk about the conversation project. Maybe give them handouts to think about and then have a meeting afterwards, or, you know, all kinds of things. So there's a lot of ways to facilitate this. Great. So I'm going to move on. You can keep typing in questions and comments in the chat box, but I want to just move on a little bit about the data collection. Next slide. Okay, so as we were talking about, we need to periodically assess the number of residents who have advanced directives. And so we would like you, unfortunately, this is not in the MDS. It doesn't say, did the resident complete advanced directives? Yes or no, right? It's not in the MDS. It's up to the facility to make sure it's done. So need to periodically look for these three things. One is that general power of attorney. Did they name somebody? Number two, did they complete their advanced healthcare directive and decide what is they do wish or not with regards to, heroics or feeding tubes or whatnot, things like that, comfort care. And then number three is, have they completed the PULSE form if they are, eligible or, have serious illness at that time. So yeah, three things to look for: power of attorney, health directives, and the PULSE form. Next slide. And so we'd love for you to take on the challenge and review, just take the opportunity to review your residents and their charts and see who does in fact have these, how many have these out of the total number of residents, and sort of see where you are, and then see if you can get those numbers up, because so you will receive a link to fill out an online survey to share how many of your residents have these three documents. And then, so try to have someone screen all your residents before our next session, and then and try to complete this. It'll help us demonstrate that you are doing a good job helping residents achieve their wishes. And of course, that makes all of our funders happy that we're having an impact on your practices in your facilities. Of course, everything is going to be anonymous, and we won't really know who these folks are, or you for that matter, but just wanted to know what kind of percentages are we talking about, and if we're doing a good job with that. Next slide. Yeah, and so Michaela, do you want to chime in?
Yes, I want to thank everybody for completing our evaluations and for helping us with this. I know Dr. Wen said that it's a chance for you to assess where you're at, but we're also grant funded, and it's how we're providing you these education for free, and it helps us understand where you are and provide some metrics that show that we're making an impact. So once you complete your evaluation that you usually complete, you'll receive a separate email asking you to give us the data that Dr. Wen showed in the previous slide. If you have any questions about the data form, you can join me on Monday, or you can email me. I just put the evaluation link in the chat box and my email in the chat box as well. So please reach out if you have anything about this, about our upcoming echoes, or about GWEP in general. Thank you, everybody, for attending.
Thank you. Okay, so you can stop the
Thank
screen
you.
share, John. And you guys have 2 more minutes if you want to talk about or question about anything else, or share any challenges or good stories.
Dana, I have a suggestion for you. So when you finish your advanced directive, take it to your parents and say, I finished mine. Can I share mine with you, to get that conversation going?
Good call.
And I encourage folks to do that with anybody. If they're trying to figure out who to have these conversations with within the family, maybe an older person in the family, you see them getting health issues, there's an opportunity to say, hey, I've completed mine. I want to share my information with you. And hopefully that opens the door for a conversation so that you can learn what their wishes are.
That's a great suggestion. Thanks.
Good idea. Nice seeing all of you.
Yeah, any other great ideas, last minute ideas here you want to share?
No, just do what you do well. That makes you happy, right?
That's right. Keep
Yeah.
doing what you're doing well. And yeah. And we'll see you next week.
Okay.
And we're going to talk about advanced directives and care planning next week.
Oh,
So,
that's going to be awesome.
okay.
All
All
right.
right. Thanks so much, guys. Thanks for joining.